get started, and then more folks can kind of filter in as we go by. Perhaps actually we can start with Dr. David Williams introducing himself to the group. I think this might be the first meeting that you've joined. This is a pretty casual venue. Usually we meet once a month. We're a global group of Snakebite PhD students, doctors, nurses, and general enthusiasts. So quite excited to have you here.
No worries. So I'm David Williams. I work in the pre-qualification department at the World Health Organization. I'm mostly responsible for the evaluation of antivenom products around the world, but I also work very closely with the NTD department on the implementation of their snakebite prevention and control strategy. By way of background, I started life as a herpetologist before I got more medically interested. I spent 20 years working in an emergency department in Papua New Guinea, running a snakebite treatment centre. We did a lot of work on snakebite, from designing and developing new antivenoms and running clinical trials, through to epidemiology and antivenom distribution and surveillance and all of that sort of thing. I've been with WHO for informally since about 2016, when they first got interested in snakebite, and I've been working with them full time since 2019.
Amazing, thank you. I think lots of folks might recognize your name here from is it the recent webinar series on
It's on
snakebite
a few of
envenoming
my
in these.
posters.
Yeah. But thank you for joining us, and
It's okay.
I've given you a little bit of a background about what we've been up to in the last couple of months. But I guess it's good to reiterate also for anyone who's joining for the first time. So the last 2 monthly Snakebite Hub meetings, we've been chatting about a standardized sort of data collection and reporting form, noting that a lot of folks here work in clinical settings and are doing some form of passive data collection for snakebite patients. So we were thinking, is there a way that we can kind of standardize what is being collected and reported, such that it kind of makes it easier to do clinical research, whether that's retrospective based on data that's already been collected, or prospective for folks who are kind of collecting data as they go. And we wanted to really focusing, was it and the film minutes to die? True. But yeah, the focus was really trying to figure out what is not just important to collect on snakebite patients, but what is feasible to collect in different settings. So perhaps what I can do is I can summarize kind of the results of what we've found out, and then I'll pass it over to Beth, who will chat about piloting this as part of a larger project in a few different settings. So I will share this presentation. If I go full screen, can you see it? Yes, awesome. So yeah, so what we did was in the past 2 sessions, we sort of brainstormed all together. We came up with a pretty lengthy list of things that we kind of wanted or thought was important to report. And that was a large brainstormed list. And then what we did as sort of a second step to this exercise, we said, okay, this list is quite lengthy. We'll circulate it and try to get a sense of different people's notions of importance and feasibility for each item on that list. So noting that, some things like ICU admission or laboratory-based assessments might be in theory important to collect, but not necessarily feasible in every setting. So this exercise was done so that we could create a sort of minimum data set in addition to that lengthy one that we had brainstormed, but also this allowed us to solicit any other sort of additional information that people thought might be missing from that data set. So people were asked for each data item to rank it on a level of 1 to 5, 1 being not important or not feasible to report, and then 5 being very important and feasible to report. So each data item was kind of assigned 2 different scores. And then did a quick sort of calculation to figure out what the median and interquartile range was for importance and feasibility across all data items. And then we identified items that were in the top 75% of importance and feasibility. Now, the 75% is pretty arbitrary and totally up for discussion. But the results presented kind of take that as a benchmark for this minimum data set. And the meeting today is to kind of discuss this and decide whether this was, it works or not. This is a quick look. If we zoom out, don't worry about reading all the x-axis labels on this graph. This is basically everything that is on that sort of very large data collection sheet, and we had divided it into sort of 5 sections. I'll go through each section in detail, but this is just to show that kind of overall both importance and feasibility kind of were similar across and quite high actually, because 5 was the highest level that could be assigned. So that's a good sign that things are both important and feasible to collect. But we can see kind of overall there was importance was higher than feasibility. So this black box here just shows what that 75% cutoff was. So this represents the top 75% of data for importance was given a score of 4.45 and above. And then the same thing for feasibility was 4.38 and above. And things that would kind of make the cut for this minimum data set would score in the top 75% of importance and the top 75% of feasibility. So they basically had to have a score of 4.45 and higher for importance, as well as a score of 4.38 and higher for feasibility. We'll kind of go through each section in detail. So this is section 1, which is patient demographics and conditions, clinical conditions preceding snakebite. The things that are highlighted in yellow are items that made the cut for this minimum data set. So things like age, sex, country of origin, county, district, state of origin, comorbidities preceding the bite, and pregnancy status were all things that made that cut. We did have one comment from someone who had filled out, I should mention, we had 38 responses to the survey. So thank you to those who filled it out. We had somebody who commented on the wording of origin, whether that refers to somebody's sort of ethnic origins or where they have come from on that day. I think based on what we had discussed, it was more of a geographic indicator than anything to indicate how far people were traveling or, where their typical residence is. But if I am mistaken, do let it be known. We can discuss that for sure. We can certainly clarify the wording so that people aren't kind of documenting different things. So section 2 was circumstances of snakebite. So these ones, again, the items that are highlighted in yellow are ones that had made the cut for the minimum data set, and we can see there's quite a bit that had made the cut in terms of, is this the patient's first snakebite or spit? We have information on time, date, and activity, place of bite occurrence, anatomical site of snakebite, and then some information on what happened before the patient got to hospital and how they got to hospital, which could be quite informative. We had somebody commented on kind of rewording self-medicated, because that can mean many different things. I think we can be quite specific as somebody kind of took painkillers themselves or, tied a tourniquet themselves, rather than seeking kind of additional treatment. But we can be very specific about that wording and make sure to standardize it so that people are documenting the same thing. Then we have clinical characteristics of snakebite, which is section 3, and you can see basically everything is in yellow here. So people, which kind of makes sense, I guess. Everyone who is, or at least most people are in some sort of clinical setting. So kind of recording symptoms and other markers are certainly feasible as well as important, except for the one thing that was bacterial infection, which may be limited by laboratory capacity. So that did not make it into the top 75% of data. Section 4 was in-hospital care. So again here, most items were deemed important and feasible, except for things like cost of supportive treatment, antiarrhythmic treatments, cost of antivenom, was the antivenom free, and then was the antivenom from hospital stock. I guess this information might not be consistently available, so was not part of that minimum data set. But other things, such as information about antivenom and then other supportive treatments, as well as allergic reaction to antivenom, these were all part of the minimum data set. And then finally, we had a section on complications and outcomes, and we can see a few of these had made the cut in terms of surgical intervention, type of surgical intervention, duration of hospital stay, pregnancy outcomes, snakebite outcomes, and sort of type of discharge associated with it. So whether it's discharge with improvement, referred to another institution, absconded, and then also when the patient was referred to another institution, if the outcome from that institution is known, to document that as well. So these items made the cut. And then, as mentioned, there was a free text field at the end of the survey for folks to add anything that they thought was missing from it. To note, these we wouldn't add this to the minimum data set. This would kind of be added to the lengthier kind of extended data reporting template. But these were folks had suggested adding things like patient ethnicity, some information about the role of the healthcare professional documenting, years of experience, type of health facility that is documenting this, scope of the health facility, whether it's community, district, or regional hospital. To add to the comorbidities preceding bite, I think right now we have things like diabetes, hypertension, and bleeding disorders, if I'm not mistaken. So it was suggested we also add something like HIV, as HIV delays wound healing. In the second section, it was suggested we add something like whether or not somebody was wearing protective clothing, distance between bite marks or fangs if available, and whether there was any community support when the patient was bitten by the snake, in terms of financial, transportation, cultural, that kind of support. It was also suggested that in the third section, we add information on not just currently we have date of hospital admission, but it was suggested we also add time of hospital admission and photos of the wound, not just at admission, but kind of throughout the period, also at discharge, wound at 30-day follow-up, if possible. It was also suggested to add something on psychological or social support provided in hospital in addition to the actual medical treatment that was there. In the last section, finally, it was suggested we add something about patient care being satisfactory and long-term mental health impacts if assessed. So these would also all be kind of added to that, the longer data reporting template. So in terms of next steps, would be to kind of discuss now to see if there's any changes people want to make, any additions people want to put in, and then the next step will be to post the minimum data set as well as that extended one onto the Snakebite Hub for people to use. But I guess the question is, what format is best? Is it best to kind of post a blank Excel file with variable names and then a data dictionary accompanying that so that people can understand in more detail what each variable means, and then people can download that Excel file and fill it? Or if people can think of other better ways, better formats to post this template, we can certainly discuss. And then kind of in subsequent discussions, we can talk about data sharing, but also we need to be very mindful of data security and patient confidentiality throughout that process. And before passing it over to Beth, maybe I will I'll stop for a second there to see if people have any comments, concerns, etc. Feel free to, we can discuss it a bit now. Okay. Does anyone have any comments? Sorry, I stopped sharing my screen so that I could see people.
One comment, it was interesting that pregnancy status did not make the cut, and then pregnancy outcome did make the cut.
Yeah. It's interesting. I guess you might be able to infer one from the other. If there is a pregnancy status documented, then the person was pregnant. Any other comments, concerns? And if not, I can pass it over to Beth.
Jacqueline wrote in the chat, good progress, great way to see the results.
Oh, thanks, Jackie. Yeah, this was actually very, very fun exercise to see what people had commented and how they had ranked different items. Okay.
Hello, Aashna.
Oh, Kwaku, hello. Yes.
Yes. So I think, as I previously mentioned, you would have to determine like the variable names
Yes.
because there is the potential to share data with other people. And if yes, they just pick the labels and change the names, it will be difficult to aggregate data. So whilst defining, either we categorize maybe group one, whether numerical grouping or using alphanumeric values, so that we know if you are in group X, for example, you are describing the demographics of the person. You can change the language to anything, but the variable name must be, say, X1 to refer to demographic, age, X2 for sex. Just mentioning things, maybe at a later time we can think of definite and proper names for the variables.
Yeah, that's a good point actually about the language. Maybe there's an argument to be made for, because I think right now it's kind of just standardized variable names by adding underscores and simplifying the language, but people might be collecting data in Spanish and French and other things. So perhaps we can assign based on those 5 kind of categories, and then items within those 5 categories, we can assign alphanumeric codes to each field, and then within that data dictionary, we can explain each code's definition in English and other languages as well, depending on what people are collecting. But yeah, certainly good to have standardized variable names.
Maybe David has a comment or thoughts.
I'm sort of happy to sort of sit back and listen to what you've all got to say first, and then we can have a chat.
Sounds good. Does anyone else have any comments before we pass it over to Beth? Okay. I think the floor is all yours.
Okay, I think let me just ask folks if they're not presenting. Thanks. Okay. Got to find the right window here. 1 second. Okay, can you all see my screen?
Yes.
The right screen? Okay, excellent. So I'm just going to take about 10 minutes to walk through this survey that we're planning. We've recently been awarded funding from the Liverpool School of Tropical Medicine and African Snakebite Alliance to conduct a 5-country survey. We've called it the Snake Study, which stands for Snakebite in Africa, Know the Epidemiology. And so the idea is that we're leveraging health and demographic surveillance systems to establish snakebite incidence and outcomes in 5 countries, as I said, Malawi, South Africa, DRC, Kenya, the Gambia, and Burkina Faso. Just as a background, the awareness of snakebite envenomation as an important NTD is increasing globally. We know that the WHO roadmap aims to halve incidence, but we also know that baseline data is fairly scanty and unreliable. We know that the countries that are most affected usually cannot implement national prevention programs at scale or provide universal access to antivenom therapy without donor support. And then we also know that there's some cost-efficient baseline and monitoring data needed to inform program planning, guide policymakers, and measure progress. And cost-efficient is a key thing. So if you think about these massive surveys, population surveys that are done, like the DHS or the population HIV impact assessments, these cost anywhere from $7 to $30 million per country to implement. So we're looking for something that's much more reasonable than that. And so I think we've managed to find that here. Well, we hope we'll find out. So our study objectives and sub-objectives, the three main objectives, one is to provide robust standardized data on SVE incidents and outcomes in 5 countries, to triangulate community survey data and health facility data to model national estimates, to strengthen research capacity by mentoring sites to disseminate their findings. So the question does become, how do we do a gold standard multi-country survey without spending millions of dollars in each country? And here we're working with, what we're going to do is work with these HDSS sites across Africa, and actually not South Asia, just Africa. Each of these sites has 25,000 to 350,000 individuals in a defined catchment area. And there are data collectors who go around between 2 and 4 times a year normally, and visit every single household and do a survey. Usually they're looking at, as a baseline, births, deaths, pregnancies, pregnancy outcomes, vaccinations, and hospitalizations. And periodically, usually every year or two, there'll be additional assessments looking at socioeconomic status, educational achievement, and occupation. Now, as you can imagine, this provides a really solid platform, if you want to call it that, for conducting additional research studies or looking at changes over time within populations. And then some of these sites also have socio-behavioral science teams who can support qualitative research, which is really important because the quantitative gives you answers as to what's happening, and the qualitative research, interviews and focus groups will give you much more insight into why things happen. So why do people delay coming for healthcare? Why do they go to see the traditional healer first? These are the kinds of questions that we can get more insight with qualitative than quantitative research. And then the second step is to engage ministries of health through the HDSS site leads to secure routine health facility data that's been collected and reported through the DHIS2. And this will be no-cost comparison data where we can compare the reported facility burdens with the study's HDSS reported community burden within the same catchment area. So we're looking at the same population and comparing what's happening out there versus what's reported in the system. Now, in green are the countries that have HDSS sites, and these are sites that are registered with the African Population Cohorts Consortium, the APCC. And the stars you can see are the places where we will be doing our survey. It was an intentional step to exclude East Africa, as they have probably done a lot more survey work and population level work on incidence and outcomes than many other countries. So we were trying to get a little bit of representation from West, Central, and Southern Africa. And of course, our budget constraint. So we have a population across our sites of 511,000 individuals, which is 12.8% of all HDSS populations on the continent. Now, what we'll do is have a cross-sectional survey that's nested in 6 sites across 5 countries. The Gambia has 2 sites that they will include at opposite ends of the country. We will conduct qualitative in-depth interviews at least 2 of the sites, hopefully 3, to understand snakebite beliefs and practices. And then we will do data triangulation and modeling using community and health facility data. And so the idea with the health facility data is that we will actually go into the facilities and collect both we'll know what was reported through the DHIS2, but then also review outpatient registers for the same period of time and assess whether snake bites were seen but not recorded as such. Or what often happens more is that snake bites are recorded under a broader category of bites or injuries, animal bites. And so you're not able to disaggregate what's snake, what's a dog, what's anything else. We're establishing a multidisciplinary study advisory committee. We're also establishing a study coordination group with the sites, where we will be looking at making sure that we have data sharing agreements in place, data management processes agreed, financial administrative oversight, and then the technical oversight on the process. We'll coordinate protocol clearances at each site. The data collection tools will be, some sites will use paper-based systems and some will use electronic, but every site will be responsible for ensuring that they have a standardized data set, which is shared with us for pooling and having a single analysis. And each site will also be able to do a data analysis for their own site. From the routine HDSS data that's collected, we will be able to get our denominator. So we'll have births, deaths, in and out migration. We have the total population by age, sex, education, occupation, socioeconomic status. And importantly, and hopefully this will be agreed in the data sharing agreements, is geocoded location, because doing geospatial analysis might actually yield some really important information about outcomes in relation to facilities or bites in relation to rivers or things like this. We'll be able to do a lot deeper analysis if we have the geocoded location of the person's home as well as the health facility. And then the snake survey itself, we want to pilot the survey that the questionnaire that you all have helped with refining. Obviously, we'll be implementing this in the community, so a lot of the detailed clinical information may not be available. We'll be doing a lot of self-report and recall, so there might be some challenges there. But in terms of information that we will be able to collect, for sure, we're talking about, you know, where the bite happened, what circumstances it happened in. If any photos were taken of the snake or the wound, we will collect those, the health-seeking behavior, treatments that were provided, and then the outcome. And we'll do in-depth interviews with the snakebite victims for those sites that are doing qualitative. The plan is, as I said, to compare with the Ministry of Health data. We're working on with the assumptions that our HDSS data provides both a robust numerator, so number of people who have been bitten by a snake, and a denominator, number of people in the catchment area. The assumptions are that many snakebite victims never seek formal healthcare, so we want to find them we want to be able to quantify the difference between what's going on in the community with what's going on in the facility in terms of reporting. And so, as I said, we'll engage the right Ministry of Health folks and follow standard procedures to access their monthly reports and send a data collector to manually review the outpatient registers and abstract any data. We will then compare the snakebite burden across data sources, triangulate and see. We have to see how feasible it is to actually triangulate the data and model national snakebite incidence estimates from what we're seeing in the ministry reports. Because keep in mind, these HDSS sites are often in locations that you tend to see a high disease burden, especially infectious disease. So we do anticipate potentially having higher snakebite incidence in those areas than in the rest of the country. So you can't take your incidence from an HDSS and say this applies to the whole country. So the idea with doing this data triangulation and modeling is to see if there's any way to generate estimates at a national level relative to data from each facility, recognizing that every facility has data. And recognizing that our sites will have the community data to work with that. And yeah, there are caveats where our assumptions can result in over or underestimation, and some of these we'll be working through, we'll only fully understand once we've collected the data and understood what's happening on the ground. When it comes to disseminating our data, we want to have maximum impact. So the idea is to have a single analysis and multiple opportunities for dissemination, and you tailor your message to the audience that you're taking it to. So everything from peer-reviewed publications, policy briefs, and presentations. And then I'll also be working with the sites themselves. We'll do a virtual writing workshop, and we'll provide one-on-one mentoring to help them do their site-specific analysis and develop their publication, presentation, or policy brief. Our timeline is, we've got a 2-year timeline. Hopefully within 6 months, we'll start collecting the data. And that will go on, depending on approval processes and which months, which sites are starting and ending data collection. We anticipate it could take up to a year to collect all of the data. And of course, we have to factor in seasonality differences here as well in snakebite incidents. And then we anticipate closing out the data dissemination by the end of the second year. So in summary, we think it is feasible and affordable to collect multi-country gold standard population-based data on incidents and outcomes. And that this multi-country survey, which is the first of its kind that I've been able to find online, this should hopefully increase the visibility of snakebite, both nationally within the countries where the survey is taking place, as well as globally. And so we're really excited to work with you guys and have all of your insights and inputs on the questionnaire and also your feedback on our study plans. Thank you.
Yay, thank you, thank you. See, Jackie's got a comment. Congratulations, Beth and team, for this important study. I appreciate it's pretty much under the One Health approach. It would be desirable to stress this approach in the background and also the analysis and expected outcomes.
That's a very good point. Thank you.
Ooh, Kwaku, go ahead.
Thank you, Aashna, and thank you, Beth. So that was a nice presentation. I just want to ask, is there a possibility of including one more country, or that is it? Because my group has done a lot of work, and we continue to do, as we are talking right now, we have two projects. One collects the prospective information for patients who get admitted, and we'll be launching an interventional study this year. So I want to believe if there is that possibility of the inclusion of one more country, I would offer my group and my country.
I really appreciate your enthusiasm. I really do. Unfortunately, the budget, as I said, is so tight that we can't add any more countries. And the importance of the population-based HDSS it's a critical piece of this. However, I will say that I'm always interested in helping folks out with their research, and I'll be happy to give you any feedback on your plans, or provide you with the support as you work through the process. If you need any help with data analysis or learning how to write up or improving your skills in writing papers or presentations or policy briefs, I'm always happy to help.
That's perfect. Thank you. Yeah, can confirm. Beth is like ultimate support for projects. Are there any other comments?
Be paid. No, I have a passion for snakebite stuff, so I'm always happy to help folks out. I won't charge.
Okay, thank you. Is there any other comments for Beth or for the data reporting template? I think David had posted a comment about pregnancy status to say clinically it is relevant. So even though it didn't really make the cut, we should still include it. It's a simple, I guess, question to include at the beginning. So we can make sure to have that in there.
Great. I'm curious to know whether anybody on the call has concerns about any of the questions that we've generated in our list of questions about using these in a facility setting with non-clinical data collectors, non-clinically trained data collectors. Are there any concerns?
Ooh, Kwaku, go ahead.
Okay, so there's always that risk of where the non-clinical data collectors may miss important information, because hospital records are meant for hospital use and not necessarily for research. So sometimes they have to flip through several pages. And from one of the projects we executed, sometimes the relevant information would be in the nurse's notes. And without somebody with that adequate training to realize that I must inspect or read the nurse's notes, some important information will be left out. So I would always prefer clinicians of any level are used to rather collect the data than a non-clinician.
Okay, so for data abstraction, ideally, we want to have somebody with clinical training doing that. And then what about in the community when they're going house to house and asking these questions? Are there anything, I mean, because the data collectors are existing people who are well trained in data collection, but won't necessarily have done any data collection on snakebite or specific clinical variables. Are there any concerns there that you think we should be careful of?
Okay, so I had this exchange with my supervisor when I was defending my thesis. Or my external supervisor, he preferred I collected community level data, but then there's always that issue of what is a snake bite. If the person is alive and didn't go for hospital treatment, it could be it wasn't a snake bite, which the person misinterpreted as a snake bite. So community level studies frequently overestimate the incidence of snake bites because it is people saying I was bitten by a snake. There is always that risk which must be accounted for somehow. So yes, indeed, anybody can collect that data because it's a matter of have you been bitten by a snake before? And they are going to say yes. Probably ask for evidence. And if it were a non-toxic or non-venomous bite, there wouldn't be any evidence. But is it the case that the person was indeed bitten or wasn't bitten, which would be hard to define at that level? If there are ways that can be like to mitigate those scenarios, fine. Maybe you can add a question like, did you go to the hospital? So that if the person did not go to the hospital, we reduce our confidence in the in what the person says.
Mm-hmm. Okay, that's a really good point. One that I hadn't actually thought about, even though I just had a friend tell me she thought she was bitten by a snake because of her physical reaction to the bite, but she wasn't sure it was a snake. So that's actually an incredibly good point. And I will have to think through how we tease that out a little bit more and how we establish that, or in potentially flag it as possibly not a snake bite. So I think I'll need to think about that. Thank you so much. And I see the comment from Jackie about documenting challenges and barriers and solutions. I will definitely do that. Thank you so much.
Oh, David, go ahead.
Yeah, so the use of non-clinical data collectors, I guess, is potentially problematic if you're asking clinical or if you're trying to ascertain whether a snakebite did in fact occur. Good example is a recent case in Kenya where a young girl was brought into a hospital, unable to walk, throwing up, exhibiting all sorts of symptoms that they vaguely diagnosed as being signs of envenoming, and then decided to treat her with antivenom. And then later the dead snake was brought in and it was a sand snake, completely harmless. So her symptoms were all anxiety, were terror. And I've seen this in practice. I've had people come in who were physically ill, shivering, shaking, stomach pains, headaches, the whole works, their blood pressure all over the place, their heart rate all over the place, and they're completely non-envenomed. And again, for non-clinical people trying to elicit that sort of information, it can be challenging. But any sort of retrospective investigation is challenging because you do, at the end of the day, have to rely upon people's recollection. And so it is one of the problems that you will face, but that shouldn't be something that says, well, don't go ahead and do it. You know, what might be useful is to provide those non-clinical people with some guidance and training beforehand on how to ask the right sort of questions. You know, asking open-ended questions to elicit information rather than prompting for specific answers. This is something that we learn in basic practice. When somebody comes in, you don't say, well, were you spitting blood? Because if they are anxious and they're hoping to get treated, they'll probably just say yes anyway. what you want to do is actually conduct a physical examination and see what you can actually find out for yourself, and then see what information they offer without prompting. So they're just some of the practical things. WHO does already collect DHIS data annually from all of the countries that you've mentioned. In fact, we've got very good data from Burkina Faso as just one example where we get, I think, reports of around about anywhere from 9,000 to 15,000 snake bites a year comes through DHIS2. However, there are some practical challenges here. They don't report deaths. They don't report envenoming. They're just reporting all people who presented with a suspected snake bite. And so the coding is not based on the final diagnosis. That's also a challenge. A lot of people will present fearing snake bite, but at the end of the day, they might actually end up being coded as something else, or not coded at all. And certainly we get no information on disabilities. So this is largely because the policy in most of these ministries of health is not to ask for, detailed information. They don't ask for deaths, they don't ask for disabilities, so it doesn't get reported. And that requires activism to encourage a change in policies to get countries to start collecting more detailed data. And I guess that's the thing when I look at your questionnaire. So to me, it is the perfect academic research questionnaire. Like it's wonderful for that extent. And if I was back in Papua New Guinea or I was in Cambodia and I was going door to door from one health facility to the next, digging out the records physically myself and then recording the data, it'd be a perfect template. But if it's something that you're going to ask, for example, a health centre to provide on every patient with snakebite they have, the thing you've got to remember, and this is what we've been confronted with, is that they're already being asked to report on every single condition. It's an enormous amount of data that they're asked for annually. And so, there's only so much that they can potentially give. And that's why WHO, with what we collect, we started with the bare minimum. We just said, tell us if you have any cases, if you have any deaths, and if you have any disabilities. And now we started collecting a little bit more information about access to antivenom. How much antivenom do they get each year? What type is it? How much of it is actually used? How much of it expires or is lost to breakage or other problems? And over a period of time, we're trying to introduce some additional questions as they get used to of being asked about it. Now, that's our DHIS questionnaire. It's quite simple. Now, we've been piloting a more complicated questionnaire with South Sudan, and it goes into quite a lot of detail about demographics. It does geospatially code where the people come from, but we do that on the basis that it's automated in the spreadsheet. So we have a geodatabase for all of the communities in the country. And so when they select the name of the village or the community, it automatically provides that into there, so they don't have to come up with it themselves. We get the circumstances of the bite, the date and the time, information about the snake responsible. In other words, was it seen? Can they describe it? We get information about traditional medicine. We've asked for information about the health facilities themselves, not just the one where they first went, but also where they may have been referred to for treatment subsequent to that. We do ask a lot of clinical information about the bite site, local signs and symptoms, systemic signs and symptoms, the use of things like the 20-minute whole blood clotting test and the results. We give them a free text option to give us, definition or description of signs and symptoms that don't quite fit the box. diagnosis. We get information on the antivenoms that we used, when they were given, so what time the infusion started, what time it stopped, what product was used, how much, etc., etc. There's also information about adverse reactions collected and information on referrals, surgical interventions, disability, and then final patient outcomes. How long was the stay in hospital? When were they eventually discharged, and any other stuff? Now, we've piloted that, and having done it, they've by and large come back and said some of our third level hospitals can give us quite a lot of detail for this. But our primary and secondary health facilities, so at the most remote area, and then at, say, the district level, it's just not possible. So we're in the process of having meetings with them at the moment to strip this right back. And it'll be very interesting to see, what the consultation with the primary health services. So these are like the small rural aid posts, and with the district health facilities, how far they want it stripped back. And I think that will provide some very useful information, because there are, two practical things here. From an academic perspective, I want all the information I can possibly get. I'm very greedy when it comes to data. But I also have to see it from the practical side of things for the person whose job is primarily to be treating people, that I don't want to give them so much work to do that they just can't cope with it. And then they either will just simply not report anything at all, or what they report will be very incomplete and imprecise. So they're just a couple of the, I guess, my observations initially. And I guess that brings me to the next logical question is, how do you hope this questionnaire will be used, and who will use it, and how would it be implemented? I mean, if it goes onto your website, it's sort of going to be a little bit ad hoc. But if you really want to see it rolled out as a tool that is taken up, then that's going to require a lot more process. It's going to require political process to a certain degree to get ministries of health to take it up and roll it out. Or I guess, of course, you could always try to promote it through some of the non-government health services initially to see if that early data that you get then builds an argument for its use that you can then take to government to persuade them that it's something that they should be using.
Yeah, these are very, very valid points. I definitely understand the practicality point. Even the minimum data set is very, very lengthy and not necessarily feasible in clinical settings, especially if people have other patients to take care of. But yeah, I guess in terms of rolling it out and piloting, Beth was maybe, I think, one of the only potential pilot plans, and then the rest was just going to be ad hoc, available as use for use. But it is a good point you raise about kind of intentionally piloting it to make a case for its use, or if we do find, actually it's not really feasible to collect that much information, we could regroup and create something smaller. But I guess it's a question for others. If anyone has any ideas, we can think about ways to pilot.
I think, Aashna, it's interesting because we just went through that process of prioritizing importance and feasibility, but we just said feasible, yes, no. And I think David's point is really important. It might be feasible in a district hospital and not at a health center. Yeah. So we might want to actually break down the feasible and important both by level of care. And I think maybe, David, after you guys go through that process, it would be really interesting to see what you guys find, both in terms of what your complete questionnaire is, as well as what you find the providers in South Sudan. And keeping in mind that South Sudan is, one extreme end of the spectrum when it comes to health systems. But just knowing what they find is actually feasible in an outpost or in a small primary clinic would probably really inform this as well for us.
100%.
Yeah, no, we're quite happy to share that. I mean, it is interesting because South Sudan's now a separate country, but Sudan, they have extensive data for everything within a fairly comprehensive system for every single disease in ICD-10. They put out, up until the war started, a 400 or 500 page report every year. And for, say, snakebite and scorpion stings, they collected data from every state. It was aggregated by age groups, aggregated by sex, and their way to differentiate between the non-envenomed, I guess, and the envenomed was they recorded outpatients and inpatients separately. So on the assumption that if you got a hospital bed and you had a stay, then there must have been something wrong. Whereas if you were only seen as an outpatient and then you were discharged, can't have been that serious, which I guess is a simplified way to do it, but it actually gave very good information. And they were reporting on average 15 to 16,000 outpatient cases a year and somewhere between 3,000 and 8,000 inpatient cases a year. And they recorded deaths as well. Again, to the aggregated by age and sex and by the state that they came from. And these reports go all the way back to 1980. So there's like 40 years of data that we have, which is really one of the best data sets we have. I'll give you a contrast. From South Africa, we have absolutely nothing. And very different socio-economic circumstances and capabilities.
That's very interesting. Kwak, go ahead. Ooh, it's a legacy hand.
Sorry, my mic was off.
Oh, all good, all good.
Yeah. So Beth was asking whether in health centers and other things the form should. Yes, I would say health centers have different capabilities, even in the same healthcare system. In Ghana, for instance, there could be a health center with a doctor, whilst another one may not have a doctor, may be operated by a physician assistant or even a midwife. So where there's a doctor, clearly they will provide some services different from the one being operated by the midwife. I would say push out the form, access. If they have the capability, let them fill in where those services like the bedside clothing and other labs services are available. It doesn't take away anything, but where the decision is made a priori to remove some fields because it's a hospital, you may hurt the process rather than so push out everything as is. If the information is there, they will provide it. If the information is not there, let them skip it. Thank you.
Thank you. I guess a compromise would be, I know someone had, in filling out that survey, had suggested that we actually document the level of the healthcare facility in, like as they're collecting the information. So we will have that. We will kind of know what level of health facility is capturing different snakebite patient information. And I guess, yeah, you do make a good point of it could be a district level hospital that doesn't have as much capacity as community clinic that kind of happens to be collecting a lot of detailed data. So I guess we could just kind of leave it up to people. I guess this would be interesting to see in the pilot as well, or in different settings where it is piloted, to what extent people are able to collect different varying levels of information, and that could help further refine it after.
Yeah, there was this scenario. It didn't happen though, but there was going to be a weird scenario where the health center was going to have a better resourced laboratory than the hospital. Somebody offered to build a lab facility for the health center, or it could have been, but something came up and he didn't do it. But there are those scenarios where out of donations and other things, so push everything out as is. If they don't have the field, I think on RedCap you can have the missing data codes that the information was not available or something. Let them indicate why the information is not available. Then you proceed. That way you don't sort of punish yourself for in advance. You don't punish yourself in advance for something that you didn't anticipate.
A good point. We can build that into the sort of options for the form. Instead of just leaving it blank, it'll be, this information was not available, and then kind of figure out why it wasn't available.
I often have found myself doing that frequently for databases I design on RedCap. Everything is required. If the information is not select why the information is not available, rather than giving you the option to say to skip it conveniently.
Yeah, this is one of the considerations WHO has, because we had to go to ministries of health and get them to differentiate between centres that reported no data and reported 0 cases, because they were just reporting all of them as zeros. In actual fact, when we got them to differentiate, we found that in many cases it was that no data had been reported, that not necessarily there were no cases. And so that then enabled them to go back, and we did this in Guinea, I think. They were able to go back and clarify that you must report a value, and at least then you either found out that there were none or that in fact there were some.
Yeah, blanks mean different things in different places.
Yeah.
I guess, yeah, it'll be good to, maybe that's something we can include kind of in the data dictionary to ensure that, when it's genuinely not available, it's not that this data was not reported, it was just not available to report. That we're able to differentiate.
As Williams was speaking, this idea, can we have data from the region with the most burden in Ghana? And we also have the DEMS. I don't know if you know about DEMS. It's like it takes aggregated data at the national level. So I think after this meeting, and maybe next week, I'll try and see and compare. We have data for about a year and a half. How many records they reported to us and how many were reported on them. Maybe in a subsequent meeting, I can share the outcome with you so that we see whether indeed they report everything in both cases or one gets omitted or any omissions.
I'm like adding you to the next meeting's agenda as we speak. That sounds fantastic. So great. I recognize that we're at the hour. Perhaps if there's any sort of final comments or questions, we can go through them now, and if not, we can break. Okay. Cool. Well, thank you everyone for this really good chat. I think this was awesome to discuss. We'll continue to work on this and then hopefully get it in use in a couple of different settings to try it out. So thank you, and thank you, David, for your really helpful comments. This is great background.
Pleasure.
Yeah.
I'll catch up with you in August.
Yes, sounds good. All right, take care, everyone.
Hey.
Bye.
Bye.
See you all.
Bye. See you.